at diagnosis, you're told by your doctor you have low-risk cancer, or intermediate-risk cancer, or high-risk cancer, or metastatic cancer that's already spread outside the prostate into the lymph nodes or elsewhere. And the reason we divide patients into these risk groups is it has prognosis outcome information, meaning, if you have low-risk cancer, you're at low risk of dying from this cancer ultimately, whereas if you have high-risk cancer, you're at much greater risk of dying from the cancer and therefore need more aggressive treatment. So there's a tremendous amount of research right now into how to better divide patients into risk groups, because we know that even though we say you're at low risk, not everyone in that group is going to be identical. Some patients, they will progress, whereas some patients, their low-risk cancer may not for 20 years. You can live with low-risk cancer. So how do you better define who has more aggressive cancers? And so for patients who on biopsy actually do have cancer, there's several actually commercially available tests that are trying to be better than a Gleason score at predicting what the outcome is. And so the most commonly known ones are a test called Polaris. Another one is called Oncotype DX prostate. That one initially earned its fame in the breast world, but they made a genetic panel for prostate as well. So I think it sounds like what you were showing me, it's another genetic kind of test where they're trying to do something, so it's not a pathologist looking at a microscope slide and counting, well, that cancer cell looks like a 3 and that cancer cell looks like a Gleason 4, but instead having some kind of more kind of objective genetic panel that says, well, the genetic score for this biopsy specimen is a whatever the score is, and therefore it's an aggressiveness of a certain amount. So it's all in trying to figure out, we know that in America, prostate cancer is the most common cancer in men, but we also know that most men die with their cancer and not from it. And so how can we better figure out who actually needs to be treated and who does not? So I think that's what you were showing me is referring to.
They say they use this in cases where there have been 2 or more negative biopsies to apparently rule out that more biopsies need to be done.
Right, so trying to sort of better define earlier on who is at risk of, for example, developing a cancer. So for example, one question that's related to this that I get asked a lot by my patients is, why do I have prostate cancer? Why is it me? And the honest truth is that most of us doctors don't truly understand why some men get prostate cancer and some do not. We know that in some parts of the world, like America, prostate cancer is incredibly common, whereas in other parts of the world, like Asia, Africa, it's a lot less common. And we know that if you take a man in his 30s living in America and you biopsy his prostate for whatever reason, you will see low-grade inflammation in that prostate. The man feels fine, he's not having symptoms of prostatitis, but for whatever reason, there's just low-grade inflammation there. We don't truly know why that is, but we know that if you took a man living in Asia or Africa and you biopsied his prostate, it will be pristine. There's no evidence of inflammation. So we think it's something in the environment, or the American diet gets blamed a lot as well. And so as men are going through these decades with this kind of low-grade inflammation in the prostate, the cells in the prostate are going through genetic changes. And it's thought that decades of this kind of low-grade inflammation eventually leads to cancer. And so this is kind of one of the tests of trying to figure out who is further along in the spectrum of genetic changes so that you're at the higher risk of the spectrum for cancer. And so it's similar, but a more sophisticated way of doing, for example, PSA testing. A lot of people know the cutoff is 4, but there's certainly, I treat many patients whose PSA is lower than 4 and they have cancer. And most men with PSA of 5 or 6, you don't have cancer, you just have an enlarged prostate. And so they try to do more sophisticated things like free PSA, PSA velocity, doubling time. And this is another way of trying to figure out, how can we subdivide patients so that you have something to worry about versus you don't have something to worry about.
Okay.
So that was interesting.
Any other questions about Joe? So you're next.
I'm going to talk to him tomorrow.
Okay. All right.
Hopefully.
Yeah.
Anyway.
Well, that's good news. I'm glad to hear him say.
I mean, I'll take.
Sorry you had to go through all that just to find out good news. That's good. All right.
But it's just I was planning on cancer and going up to Proton.
You want to see Seattle too, right?
Yeah, I was going up there and introduce myself and have them show me around.
We hope to be the nicest people that you hope never have to see. So I'm happy for you that you don't need our services.
Yeah, exactly. Okay, let's see, just a couple of things. Go ahead, Bob.
A question before we leave this. I'm supposed to start Lupron tomorrow. I had it mid-16 and I had this kind of a brain fog that this gentleman described.
Okay.
I'd like to know if anyone else in here has taken Lupron and had a memory or mental problem with it. Anyone at all? One? A little bit? Okay,
Maybe.
a little bit?
Yeah, but
Okay.
it's getting better as time goes by.
Okay, are you still on it or did you?
No, I'm not.
Okay. Thank you.
Why do you ask that question? Because I took a Lupron when I was about 40. You're a lot older than 40.
I'm 70.
Okay,
And I
well,
took-
maybe you're already having.
When did the fog start?
Support me. Both of us said the same thing. Maybe you're getting old. Okay.
I'm never allowed to say that on occasion, but you can say that to each other.
All right.
Thank you.
So I would just ask this gentleman though, how long was it after you stopped taking Lupron that you began to see a transition back to normality?
About 4 months. Yeah. And then the heat also dissipated. Yeah, they just kept doing. That's 4 to 6 months.
Okay. All right. Well, good discussion. Thank you for all the folks that shared. Thanks for your input, Pat.
Okay.
Let's see, Jack, do we have any events coming up that folks should maybe know about to start planning for?
Have you all heard of Facebook?
Yeah.
Yes.
And the group's on it.
Tacoma Prostate Cancer Support Group has a page on Facebook. That page, if you go to that page, you'll find out more about something that's happening Thursday evening at the Fred Hutch Thomas Building. And it is molecular biomarkers for prostate cancer detection and prognosis, decision aids, or decision made by Dan Lin. And we all know that name. He's been visiting this group by Skype in his office. So I suggest you take it upon yourself to go to our Facebook page, find that, click on it. That's all you have to do, because it's going to notify you at 5 p.m. on Thursday that Dan Lin starts his presentation. Please consider doing that. I just put it on the site today. I was worried about it working. Fortunately, Jack Sellers, when he and I were talking before the meeting, said, "Oh, I saw your post." I said, "What does it look like to you?" He said, "It looks like it worked." Man, was I relieved. I had no idea what I was doing. Typical the way I operate, but nevertheless. Now, that's what's going to happen on Thursday. Can we talk about our next meeting now, or you want to do that
Sure.
afterwards?
Yeah.
Denise Fikes will be with us again next meeting, next month. Remember, she was here in October and talked about cleaning your house and all kinds of things. She's coming back to talk about, guess what, downsizing. Anybody in the need for downsizing your home and shelves and closets and all that stuff? John, did she talk to your group about downsizing?
She talked to us the second Thursday in December at Lakewood United. It was one of the best presentations that our group ever received. Everybody was extraordinarily happy about what she said and how she helped them.
She's a little dynamo, and she's got a lot of
Right.
good information.
So
for
what
you,
I'm saying
and
is, if you
have a
missed
lot
it,
to
be sure
share
to
with
be here
her.
to see her. And she's not a bad-looking young lady either.
She hadn't noticed yet.
Well, she puts out a newsletter too.
But
to
she
this
is a
group.
dynamo, she's got a lot to
Get it.
offer, and you have a lot to offer to the group in the way of downsizing. You'd be surprised at how much you can be involved in this whole procedure and the process that she explains to you. So, that's gonna be on,
February what?
meeting, February.
February what?
Fourth Tuesday.
What?
Fourth Tuesday in February, right?
Okay, it's the fourth Tuesday in February, that's the 24th.
Calendar, what is it?
Okay. Any questions about that? We have a new date for IPCR. What does that stand for? Institute for Prostate Cancer Research, Pete Nelson's group. Excellent presentation. It's a whole day of seminar involvement. You'd be just absolutely marveled at the presentations, the quality. The first time you go, the second time you expect that,
That's
and
good.
never
I just had a
disappointed.
conflict.
That's gonna happen on April 28th. We often have
When is
7 or
that?
8 of the group attend that, and it's always beneficial to you.
We
Relay
do
for
try
Life,
to switch the
Working Cancer Society,
content
Relay
from
for-
year to year.
I'm sorry, go ahead.
I was gonna say, we do try to switch the content from year to year for the IPCR meeting so that it's a different content every year. So even if you have gone before, there should still be something new to hear even this
What was the date again?
April 28th.
Correct, April 28th. Now, I want everybody to understand this, not PCRI, that's the Prostate Cancer Research Institute. That happens in Los Angeles later on in the year, September. Don't confuse this with that, because they're enough different, so you need to go to both. Don't they, Steve? Yes.
It would be really nice if there was one or even two people that would go down there, even we commonly funded that one or two people to be at PCRI, because it is a chance to get a slant outside our own region. And also talk about second opinions that are free in California, even for an out-of-stater. That blows me away. You know, you can go to a source that will do your assessment and not charge you for a second opinion. And you get that at PCRI, and I'm sure many other forums like that.
One more pitch, one more ad, since we're on the advertising. The Northwest Prostate Cancer Conference will be held Saturday, September 22. This is Team Hagano that sponsors this. Once again, a very worthwhile event. Questions for me? I've talked too much. It's all yours.
Okay.
I have a question. For the rest of the group, how do we access the website, our website? What's
Facebook?
The
Facebook?
Facebook?
Yeah,
Well, first of all, you join.
right, I'm in there.
That's the easiest place.
Right.
And usually when you join, it instructs you on various and sundry things. Mine is set up so I have all my main stuff here. And off to the left is a column of things that I can click on. One is Tacoma Prostate Cancer Support
Right,
Group.
just type it in.
When you open that, it'll lead you to the posting I made today. We don't take advantage of Facebook like we should because it's free. We had a website at one time. It was expensive, tough to maintain. It's pretty simple for us to maintain the Facebook page. Please take advantage of it. Thank you, Doctor, for the interruption.